Morning, everybody. Welcome to Grand Rounds. I'm so excited that you're all here, and thanks to those of you who are online. As usual, if you're online, if you have a question for our speaker, you can type it into the chat box, and I will be watching that during the presentation and ask your question at the end. And now I get to turn things over to Dr. Webster, who's going to introduce our speaker for today. Thanks, everybody.
Good morning. Welcome to the annual Kate and Holt Webster Lectureship in Child Protection, or Child Abuse Grand Rounds, as we know it. This is a generous gift many years ago from the Webster family, and so every year we get to do this Grand Rounds. So we're so happy today to welcome Dr. Natasha Schur, the well-known and accomplished pediatric geneticist from the George Washington School of Medicine and Health Sciences in Washington, D.C. Dr. Schur is known to us in the field of child abuse pediatrics not only because of her publications and her contributions to the academics of genetics, but also, and not only because she's also a very good teacher, but mostly because of her attention to the intersection between genetics and child abuse pediatrics. She's contributed a significant amount, teaches on this, and really makes most of us smarter than we were before, and explains to us how to understand these connections. And so it not only makes our thinking better and our approaches better, but actually provides really much better care for children and families in these difficult situations. So without more ado, I introduce Dr. Schur.
Thank you so much for having me. Can everybody hear me? It's such an honor to be here with you. I'm so grateful. This is one of the most world-renowned programs in child advocacy and protection. You all have written the statements. You've done the work in connective tissue and other disorders. So it's a real privilege to come talk to you today about my field and the intersection, best genetic practices in child protection cases, thinking about how to dispel mystery and myth in rare diseases and really just clarify. And in case some of you haven't had coffee, your wonderful Seattle coffee yet, I thought I would show you one of my patients. She has Down syndrome, and she's a real joy, and that's really my favorite part of these clinics. I don't have financial disclosures, but I will say that when I went into genetics, it was the tourist trap version. There were about 5 or 10 tests you could order at the time, and you just got to spend time reading articles and hanging out with patients for an hour, each patient at a time. This is Dr. Marion, my mentor, and he's with a patient, one of the first to receive enzyme replacement therapy for meritolame, a condition where mucopolysaccharidoses, or GAGs, these sugar molecules accumulate, and the enzyme she receives helps break them down. So genetics is really full of miracles still today, and was back then. In addition, I still get to spend most of my week in those wonderful genetics clinics, in craniofacial clinic, for example, multidisciplinary clinics. So people commonly ask me, how did you get involved in these cases? And I see Dr. Carol Jenny in the room, who's one of your world-renowned CAPS, child protection advocates in this world, who's been here in Seattle, and she happened to be in Rhode Island. And you can see my friend Kristen in the green, who Dr. Jenny trained as a fellow and who lived on the 3rd floor when I lived on the 1st floor of a building. And of course, Dr. Fortin, Dr. Jenny started to involve me in these cases. And as I became involved, I was really inspired by their work. So years later, when I saw that there were cases where there was confusion between genetic disorders and child abuse, I felt that they had trained me and opened my eyes, and I was in a unique role where I could really try to help provide some clarity. And that's what my focus has really been in many cases. And as you all know, April is a very beautiful time, an inspiring time across the country and around the world for us to think about a renewed effort to how to help our children and protect them. It's National Child Abuse Prevention Month, and this year's theme is Powered by Hope, Strengthened by Prevention. It's really a time to celebrate all of our children, and you can see that among these kids, there are groups that have albinism, a genetic condition where you're missing some pigment in the eye, the skin, And for many decades in certain countries, these kids have had a great stigma. In many places, they've been ostracized, but through this positive exposure movement, by celebrating these kids, by showing just how beautiful they are, and recognizing this disorder, there have been great strides that have been made. And that's what this is all about. However, in the world of clinical genetics and child advocacy, there is a pattern where often the burgeoning, incredible scientific advances and our great discoveries precede our policies for children. And you can look at the history and think and see how that has happened in those examples. So for example, in 1953, Watson and Crick resolved the DNA structure, that double helix, a great achievement. And in 1956, Tiho and Levin discovered that human cells contain 46 chromosomes. Before then, you could be a cardiologist, a gastroenterologist. But what could a geneticist order? There was nothing they could do. In 1959, Lejeune discovered patients with Down syndrome, like this cutie in the picture, had an extra chromosome 21. But at the time, all those discoveries preceded the policies with children, because at the time, the cultural milieu was that children were worth their future as laborers. There wasn't this inherent idea that children were a miracle to be celebrated just because they were born. It was only their future value. And so many parents were told to institutionalize their children, and the diagnosis was only made in order to provide that recommendation. Not all the things we know we can do for children today. And in 1962, in a time when child advocacy in the 50s was really making some movements, Kemp coined the term battered child syndrome. Only then, because only if you could call something, if you could diagnose it, if you could recognize it properly, could you actually provide treatment to the child, just for that miracle of being born, just for being. And in 1989, the United Nations advocated for the rights of the child, because remember, the advances precede the policies. And yes, this may just be a symbolic gesture, but it was an important policy change. And 196 countries to date, I believe, have ratified this. But I'm wondering when you think the United States might consider to be that 197th. When you look at genetic testing by the decade, you can really think about how with every advance, and it's happening so fast, there always has to be this pause to say, but what about the policies, the way that we use these tests for our children? So what I'm gonna do, because I'm 3 hours ahead of you on the East Coast, is I'm gonna give you a 30-second whirlwind of genetics by the decade. I'm going to talk really fast. I'm gonna leave so much out. Brace yourselves. Are you ready? So in the 1960s, I told you by then we had chromosomes, so you could diagnose things like Down syndrome. Leap forward to 1990, the fluorescent in situ hybridization probe was just coming out. And so you could diagnose small pieces missing or added across the syndrome. Your microdeletion duplication syndromes. Has anybody heard of 22q11 deletion syndrome, Williams syndrome, Cree-Duchat, Wolf-Hirschhorn? The kids that had multiple dysmorphic features, facial features different than their parents, and congenital anomalies. And in addition, in 1989, Francis Collins, he became the genetics rock star he is today, along with Dr. Chu, because he sequenced the entire cystic fibrosis gene. And all of a sudden, if you could sequence one gene, that meant you can sequence more genes. And that led to our Sanger sequencing. You could order one gene at a time, like Marfan syndrome, and so forth in the 1990s. And in addition, that led to this idea that you could order several sequencing panels eventually, an epilepsy panel with maybe 80 genes at a time. And then let's skip to the year 2000. The rough draft of the human genome is complete, and we also have our microarray. That's like fish on a chip or fish on steroids, where you can look across all the chromosomes for pieces missing or added. Skip to 2000, we start to have exome, where you can take all 20,000 genes, sequence the exiting portions to find clinically relevant abnormalities. And in 2020, genome by now is coming to clinics. It's increasingly being used. And is anybody overwhelmed yet? Which decade? Which test do I order? How do I wrap my head around all of this? I think we all are, right? And so there is a very basic way to think. Let's bring the policy, the test, the burgeoning advances back to my case. Let's think how this will affect the child before me. Is it going to help the child with those basic skills, the love and care, the proper nutrition, the medical health they need, those building blocks to grow and thrive? And with all the things that they started to really advocate for in the 1950s, that children's rights should also include that health care, the education. And if you ask yourself, how is this test I'm going to order, how will it help the child? Then and only then will you have to decide what is in that test. What is the test doing? And so that question should be documented and answered before every genetic test is ordered. And I think all of you here are doing that. This is particularly important in our most vulnerable children, those where there has been suspected child abuse. I believe the incidence of child abuse overall is over 1 in 100 babies. And what I want to focus on in this slide is really 3 things. The first is the incidence of rare disease versus child abuse. So in terms of incidence, osteogenesis imperfecta, which is known as brittle bone disease, where you have an increased likelihood of fracture, is about 1 in 10,000. Genetic metabolic disorders and fracture cases, those severe enough to present to the hospital, are about 85 out of 10,000, including osteogenesis imperfecta in that and every other genetic disorder, as per the landmark study done by Leventhal and their team. And the incidence of abuse represented in the third pie is about 2,490 out of 10,000 cases. So about 25% in those children that present with even one unexplained fracture at the age of 1 to the hospital. So my second point here is that, as your child protection pediatricians will tell you, if you are a doctor that sees a child, a 3-year-old with a sore throat, petechiae, fever, and there's a 25% chance of strep, and you order the throat culture, you are the same doctor that when you see an unexplained fracture, and by the way, this blue part includes known car accidents, witnessed falls, you are a doctor that's going to order the skeletal survey, and you're not going to ask if the dad is a senator. And likewise, if you look at that middle chart, you are also not going to say, oh, this is a single mom and she has purple hair and she doesn't seem so nice, so I don't need to consider genetic disorders, because there is a small sliver of kids where there is a disorder. So how do we do that? And that is the goal, to really talk about using a case-based learning approach and to show how evidence-based medicine is really our best test, those decades of clinical medicine at work, better than any test you can order, the clinical process. Minor details have been changed in these cases to decide whether to test or not to test, the judicious use of these wonderful tests for the right people at the right time, and key talking points to dispel mystery and myth in rare disease. And that means your approach is going to be the same approach for this little girl in the braids who may have presented with a submucous cleft palate, tetralogy of Fallot, hypocalcemia, 22q11 deletion syndrome. You order a microarray, and the child next to her who had very short stature and a fracture, she has osteogenesis imperfecta, and you ordered COL1A1 or COL1A2 for 90% of cases. The approach is the same. So let's take a case. We're going to do 5, so bear with me, of unexplained fractures. This is a true case. The mom is 36, and she delivered at 31 weeks, so they were premature triplets. And on day of life 6, one of the babies was noted to have swelling of the left thigh, irritability, and discomfort. And the skeletal surveys showed multiple fractures. These are the two twins, the two that had fractures kind of combined. But when you look at these radiographs, it's pretty obvious that they're a little bit ribbon-like or gracile, those bones, right? And you can see, in addition to fracture, that the upper femur is a little bit bowed. And so what you really want to do is you want to take a step-by-step approach, and you're going to do a far more detailed clinical analysis. You're going to use your resources, clinical synopsis. You go there and it will show you all the signs and symptoms if you're worried about osteogenesis imperfecta, and gene reviews will too. And you're going to highlight the things that match. And then you're going to name your category. Which decade would I have been able to diagnose this? The 1950s? This isn't Down syndrome, right? Or the 1990s with the FISH test? Or would I have needed the single gene test before you order the test? It's that simple. And it's the same process for this child up above who had periorbital edema and a very bubbly personality and growth faltering, and she had Williams syndrome, and the child below who has autism and intellectual disability and a family history of premature ovarian failure and has Fragile X. That's a repeat disorder, and that's what we order. And this other child above who has pulmonic stenosis and Noonan syndrome, and the one below who has osteogenesis imperfecta. The same process every time. And so that's what we're going to do. So we see that if you do a very detailed analysis, that this patient had intrauterine crowding, a few childhood fractures in mom, who had a broken toe but not much history. The growth curves showed a little shortening. There was osteopenia, thin bones, and so we did do molecular testing. We were worried about osteogenesis imperfecta, and the 2 of the 3 triplets did have the genetic change like most. Now, this was an unusual time to notice fractures, but it is true that in OI, most people who fracture either in utero or when they're ambulatory. There are some exceptions, but really it's that head-to-toe process. So key point number 1 is that rare diseases have clear signs and symptoms. And the first step is to look head to toe, and it starts with the skull, because the body does this amazing thing. If there is a problem with bone ossification and those sutures aren't coming together, kind of like jeans you would wear where people didn't like the holes before that became fashionable and they patched them up, the body will patch up those areas with these little pieces of extra bone. And you can see that even in typical children. But there are 3 points I want to make about Wormian bones. And the first is, how many would you really need to see in a child to think there was a bone disorder, a problem with the ossification, not just a little patch, but many patches like the picture I show? So there would be 10, and there would be a certain size they were, and they would be in this mosaic pattern. And what percentage of children, even with the most mild osteogenesis imperfecta type, would have Wormian bones that were atypical in number? And the answer is that in the most mild type, over a third. In the moderate type, over 3/4, and in the severe type, which is very obvious, almost invariably all. So we really need to look from head to toe. And then, of course, other disorders of bone, anything that causes problems with that bone ossification, can also cause atypical Wormian bones. They're not all associated with fractures. Does anybody know what those are? Anyone want to name out? Yes, I heard cleidocranial dysostosis. So I'm not going to belabor all of them, but the mnemonic is pork chops. Yes. So now we're going to go to case 2. This was a 3-month-old baby who was reportedly perfectly fine until her mom noticed a swollen arm, and she was brought to the ER. In retrospect, the father recalls 2 days ago he went out to smoke. He saw her fallen from a swing onto a carpeted floor, thinks the toddler pushed her, and everything was okay except multiple fractures. And here they are. I don't think you have to be a radiologist to see the broken bone. There's also a mid-humerus shaft fracture, and there was a CML that you can see. And so here, the key point, number 2, is to rule out a genetic syndrome. Remember, we're comparing, contrasting, we're matching. You consider not only what you see, but what you do not see. Because really, you are doing, with your clinical evidence-based exam, a Bayesian analysis with pretest and post-test probability in your head. So if something is going to be like OI, about an 8 in 10,000 chance when they're presenting with fracture, but now you don't have the blue sclera, which can be found in typical children, but you don't have those, there's between a 1 out of 10 chance that this baby still has OI. And you don't have the Wormian bones. Now there's a 3 out of 10 would have had the Wormian bones, and you don't see a triangular face, and you don't see the bowing. And yes, babies don't have teeth, but 40% of families will have a family history. And so you're adding in those numbers as uncertainties as you go down your beautiful exam. And suddenly, with each probability, you're seeing that there is less and less chance of OI unless it's there, and then you're doing the opposite, right? Does that make sense? And so same with the growth curves. Growth curves are a gold mine because in children with bone disease, their bones tend to be shorter. So even in the mild type, you are going to see that they're not going to be tall like they have Marfan syndrome, right? And if their parents are tall and they tend to be tall, it's probably not OI. And Janet's length was very different. And in the more moderate type, the kind with the white sclera more commonly, they meet criteria for short stature, which is less than 2.5 standard deviations below the mean. So those growth curves are so important to look at. And you also want to compare and contrast. There are 20 molecular types of OI. That is so overwhelming. But really, you have to just decide, is it mild OI, the kind where you may actually not see as much on the radiographs, although you usually see something? Is it moderate? Or is it severe? In the severe, there's no way you're going to mix it up, right? You can see the difference in the severe form. And in the progressive deforming, it's called that in those type 3s because you get more and more bowing. So it is so important to look at those radiographs. And people mention a few other types of OI in the differential for kids that present with fracture. And again, most of the kids might have some of the hallmark features. That calcification of the interosseous membrane, radial head dislocation. Can anybody see on the physical exam? Would you be able to see if you looked carefully across the bones and felt the hypertrophic callus? You can see it, not just on X-ray. And these radiodense bands are reported in some cases, but this is a child who's been receiving bisphosphonate treatment where you might see those bands. In addition, people talk about another rare type, and it's called type 6. And that is a type that's very similar to the more moderate types. Now, in this particular type, there have been maybe 5 or 10 cases in the world where children did not present right away with deformities. They probably had a vertebral fracture, not all of them, and so there's a fear of missing this. But interestingly enough, this is a mineralization defect. And what would be something that's up if your bone is constantly trying to mineralize, but can't? And the answer is that ALK Phos would be very high and stay persistently high, not just from the fracture in these cases. So there's always going to be a clue. And so when people talk about these huge molecular panels, so many tests, we really have to think back, but which types of OI, the more mild ones, are really on the differential? And we have to, again, look at all the different clues and the natural history, because in mild OI, the natural history is usually fractures when ambulatory and less than 1 a year. Of course, I've seen some exceptions. And in mild to moderate OI, yes, the kind with in utero fractures, usually around 1 to 3 a year. The reason the triplets were affected that I showed you was because of intrauterine crowding and prematurity. And by the way, those triplets, I wrote a note for in the emergency room in case they ever presented with fractures. They never came back with routine care. They never needed the emergency letter because so many people with OI, like the mom, don't really fracture as often. Some people do, but it's less common. So we really are going to look at the fracture pattern. We're going to look at everything, the fracture type. And In child abuse and OI, it's not that you have one fracture that's diagnostic, but there's a pattern, and that's what all of our child protection pediatricians are trained to do. And you can really look at things that are high specificity for abuse, multiple fractures, more than one stage of healing, these CMLs, like in Janet's case too, the rib fractures, especially posterior lateral from this mechanism, most likely of violently shaking, versus the more commonly OI, anterior fractures of the ribs, and more commonly in OI, you would see radiographic thin ribs when you see those. And you can really think if it makes more sense for child abuse versus OI. And so in this case too, we really did a multidisciplinary evaluation. The fall onto a carpeted floor was incongruous with the injury. The vitamin D was low, but not in the range of rickets. And in addition, there were bruises on the chest. And one thing that people constantly ask me, they say, but OI, this disorder has easy bruising. And I tell them, please understand, there is a difference between easy bruising, you fall and you get a bruise more easily, you're ambulatory, it makes sense, and unusual, scary bruising in the torso, in the face, patterned bruising. My children with Ehlers-Danlos and OI, they don't come in with patterned bruises. There would be fire alarms if they did. So don't mix up easy bruising with unusual bruising. And there were radiological findings that we saw that were concerning for child abuse. Nevertheless, even though our Bayesian analysis would have said the chances left over are about 1 in 500,000 at this point, testing was ordered, which returned as negative for OI. The most common 90% of cases are these genes, especially the mild ones. But is this reproducible? And it turns out that there have been small studies, and the work we did on Janet is reproducible. Dr. Greeley saw that in the natural history of OI patients, they really could find something on virtually everybody, and none of them came in with classic child abuse or fractures that really raised concern or more specific for child abuse. And Dr. Zarate and Peter Byers, who's wonderful, is in this room too. He's done such groundbreaking work in OI. And they looked at cases, now this is a small study, where preclinical suspicion was very high of abuse. And all those people, when they ordered the molecular testing, it did not return with changes pathogenic for OI. But in Janet's case, this was the defense expert opinion and one of the things that drew me in to contact Ray Helfer. In conclusion, I do not personally know Janet or Blank. However, and I changed the name, of course, what I can say with high medical degree of certainty is that Janet has the genetic syndrome Ehlers-Danlos syndrome type 3. This is on the basis of documentation. Keep in mind, I examined this patient and found nothing but broken bones and white sclera, a beautiful baby. Orthostatic hypotension, gastroparesis, hip dislocation, on and on, 50% chance of acquiring. He also diagnosed both parents. And he said, therefore, this is a bone fragility disorder. Now, there are multiple things that concern me about this expert opinion. Number one, babies are naturally flexible. This is a disorder of glue, the connective tissue, not the bones, like osteogenesis imperfecta. Number two, we don't do Baton scores on babies because they're so naturally flexible. We don't twist them into pretzels. That's not how we treat a baby, and it says so in the 2023 Ehlers-Danlos syndrome guidelines. And number three, there have been multiple studies looking at people who truly have this disease and looking back, did they have fractures that looked like child abuse when they were younger? Our gymnasts, our swimmers, they don't present like this, or they wouldn't be able to be in the Olympics when they're flexible. And finally, the 2025 Young Children with Fractures for Child Abuse report, endorsed by all these beautiful organizations, has put in more language about these legal challenges. And they write, experts from many subspecialties have exposed temporary brittle bone disease, which is actually very similar to the Ehlers-Danlos argument, this idea that bones could just be temporarily brittle and then they go back to normal, as a dishonest sham. Words of the AAP. Another flawed explanation for fractures during infancy is an undiagnosed genetic disease like hypermobile EDS. Again, this represents a false explanation. So there is growing awareness that there is a small handful of clinicians who proffers false explanations, fabricated theories, alternative theories. I like to call them fake zebras. The idea is that rather than doing the stepwise, wonderful multidisciplinary work you do, they look at these cases and they come up with many, many ideas that OI is missed all the time, hypermobility, temporary brittle bone disease, low vitamin D, 20% of the room has it and we're not breaking. That's different than rickets, and I've seen rickets cases. That this was a small fall, that clinicians are just off, and my favorite, vaccines. A lot of disinformation we face. And if you listen to Dr. Nancy Harper, the president of the Ray Helfer Society, she will explain that this isn't misinformation. I don't know the motives, but this is disinformation. It takes away time from our children. And just to give you an example, I thought about my craniofacial surgeons I work with who are amazing. And I thought, let's say one of them walked into the room and he said, oh, look, there is micrognathia. There is posterior displacement of the tongue. There is airway obstruction. And that is the classic triad for Robin sequence. And there's even a U-shaped palate in the back. And then he called our renowned ophthalmologists and they said there's vitreous abnormality. And they called genetics, and we said this is Stickler syndrome, and that is the cause of the small jaw, a connective tissue disorder. And so now we wanted to focus on treatment. But instead of focusing on treatment, they said, no, this is low vitamin D rickets. This is the vaccine. This is OI. How long do you think our surgeons would tolerate that? How long do you think it would take the AAP to issue a statement and many statements about all of this? Because if we don't do anything, it takes away time that we could spend helping on the policies that do work for our children. And I think now is a very important time for us to bring good information. And I haven't even gotten to the genetic testing, all those decades, right? So now when we go to the real world genetic testing uptake in cases like Janet's, it's different across the country. Every institution has their own policies. So some places like Children's National on the fracture cases alone without obvious concomitant signs, they tend to send the most common genes, COL1A1 and COL1A2 for osteogenesis imperfecta. Okay, some places also include a larger panel, including that type 5 I showed you, because there's a concern maybe it could be missed by radiologists or something. There are only a few variants in that gene. Okay, there's still a low chance of variants of unknown significance. But some places send these huge fracture panels containing hundreds of genes that are not on the differential. So for example, this little girl has a disorder where she has a very short chest, extra fingers. She didn't even present with fractures, but she has a disorder called Ellis-Van Creveld. It was on a skeletal dysplasia panel that somebody sent in a child abuse case, and it came back with one variant of unknown significance in an autosomal recessive disorder where you need two. But do you think that caused any confusion? It certainly did. And then other places don't do testing. So what is the right thing to do? And I think the right thing is to have a lot of clarity before we test in every situation. Because in the real world practice settings, as I've been trying to show you, key point number 3 is clinicians can tell apart zebras and horses. But what I want to ask you is, in these pictures, does anybody know which picture is a fake and why? So I really like how the patient with Down syndrome is riding a horse with a helmet. Good job. Great therapy. Number 2, just a zebra and horse together. Number 3, there are actually hybrids. But number 4, zebras don't like to be ridden. They will bite. And this child is not wearing a helmet. And luckily, that is the fake. It takes some expertise to really be able to point that out for people. So in courtrooms, it may be harder to spot the fakes, but with clarity, with our own process unified, I think we can show how we do things to really make the diagnosis when it's present. But here's where defense expert 2 came into the picture for Janet and many other kids across the country, and he ordered molecular autopsy. I had to look that up. It turns out that is exome, where you go across all the genes, and there were 3 variants that returned. And do you see all the likely pathogenic? So once you get variants back in a case like this and you see 3 likely pathogenics, you are going to think that the doctors, the process, years of evidence-based medicine were wrong with this one report. And so what do? How do you analyze this report? And so there are all these complex but very good variant classification schemes. The idea is you take your pre-test probability that the gene could have a pathogenic effect in the body using databases of other people reported with that same variant, using studies in the lab, how likely, functional studies, literature review, and then you also consider the phenotype. Does it match the syndrome? So your phenotyping is so important for pretest probability, but I try to make the process simpler. So the first thing I do with a case like Janet's is I say clinical pretest probability. It didn't fit. The second thing is that for SERPINF1, there was 1 variant found, but it's an autosomal recessive disease. So for autosomal recessive diseases, how many variants pathogenic do you need? 1 on each allele inherited from the parent? Usually 2, right? So that wouldn't work. And the other conditions were adult onset. So these hereditary hemochromatosis cases where you get iron load, and if any of you in the room have it, you probably donate blood ever so often to get rid of the iron, that wouldn't have caused this injury. And then there's the inheritance pattern that you have to consider. And also, there was a variant of unknown significance in ALS. That's a very serious disorder. And now you're taking a vulnerable child and you're saying you might have an adult onset condition where you need to worry about your iron years later, and you may have ALS and have a degenerative disorder later. The parents didn't follow up for testing. Our post-classification case was abuse, but in the courtroom, it was a very different classification scheme. And so the key point number 4 is that genetic testing in and of itself is not a cure and can be a complication, because there is so much when you have a vulnerable child. You have to think about all the long-term consequences, the potential for exclusion for life insurance and the military if they have an ALS variant, the misdiagnosis, the incidental findings, over-medicalization, home placement. So how many people want to go back to the year 2000 now? So on to case 3. We have a 13-month-old switching gears with subdural bleeds. The 13-month-old X35 weeker with severe epilepsy, he presented to the pediatrician due to 1 day of poor feeding. The mom denied fever or a URI, and at the pediatrician's, he had hypothermia and bradycardia. And the CT scan showed subdural, bilateral subdural fluid collections. And the physical exam was quite notable for some findings. So the first thing, remember the growth curves? When you have a 13-month-old baby with Menkes disease, what are they the size of? They're the size of like a 4-month-old. So if you know what size babies look like, you really aren't going to miss it. They're very small. You have to look at your z-scores or your standard deviations, because 3 standard deviations below a mean is about a 60% chance of an actual serious medical condition. And once you hit 4 standard deviations, you should have fire alarms in your head that something is wrong. And this is a disorder where copper doesn't process properly, and you can have low copper, which is essential for many functions, or high copper. And so you see neurological damage, very small heads. You see the unusual hair. You see hypotonia, elastic skin. So you see very clear signs. And in addition, even the MRI at 2 months showed a thin corpus callosum, because this is a neurogenetic syndrome and cerebral atrophy. And how many people, because the copper-dependent lysyl oxidase causes a failure of elastin. And so the veins, due to that, become tortuous. How many people in Menkes disease have this tortuosity that you can see at the MRI at the same time as subdurals? And the answer is 75%. And about 100% have significant microcephaly and all the physical exam signs. So key point number 5 is that subdurals and syndromes are syndromic. You don't just see an isolated subdural. You see a diffuse process that has caused brain injury and left the brain chronically more vulnerable. And that's very different than child abuse, correct? Subdurals and syndromes are always syndromic. That's why our neurogeneticists are so important. And so when you look, you can diagnose that this baby is that 1 in 100,000 that has Menkes disease because of the history of hypothermia. The family history wasn't significant. The laboratory values were significant. The severe small size, the physical exam, and in addition to the MRI findings, you often see wedge-shaped calcium deposits at the skull of the occipital horns. Molecular testing is about 100%, and there is no mixing it up. So how come the literature review has dozens of reports of Menkes mimics? So I looked back at all those reports, and you see one review, and out of 35 children, one child with a known Menkes disease variant, known diagnosis, was investigated, but after the investigation was returned to the family, I don't really understand that particular case or what happened because the child had the known disease. And when you keep going down the literature, there was one other case where the case was found unfounded during the very hospitalization. And in the other cases, there was not a mix-up. Child abuse wasn't even raised, but the authors forewarned this could have been a mimic. So be careful, do your exams, but we do know that, right? We do examine people. And so this brings me to key point number 6. Rare disorders are not mimics because when you look, you can tell them apart, but they are in the differential diagnosis, and we must consider them every case, every time. So I have 2 butterflies, one above and one below. Does anybody know which of the butterflies is poisonous to predators? It's the monarch butterfly, and the viceroy has been adapted over time, Darwinism, evolution. The viceroy looks a lot like it, but experts can, when they look closely at the butterfly, see the lines that I pointed out with the arrows. However, children are very different, in my opinion. As a mom, if you had met my children, you would know, and if you meet my teenagers, that they are very capable of showing if something is wrong and showing what they want and demonstrating. They're designed a different way. They are not designed to be mimics of something else. They are designed to get the help they need when we look and spend time with them and get to know them. And so which of you would order a ceruloplasmin on baby 1 versus baby 2 if you could order only one ceruloplasmin in this room? I think all of us would agree that we would order the ceruloplasmin on patient number 2. So then what I want to go through as we go through the next case is thinking about when we order those tests and consider those diagnoses. So now we go on to case 4, metabolic disorders demystified. We have a 13-month-old with slight low muscle tone who had a fever and a cold. He began to stop moving his arm. He had dystonia, and the physical exam was notable for macrocephaly. And here is the picture. This one is actually from the literature, but you can see that my patients who have this condition present with macrocephaly, lingual dystonia, dystonia of their arm. Their arms are dystonic during viral illnesses. And again, you can see that there is macrocephaly and that their MRIs show an unusual pattern, periventricular hyperintensity, basal ganglia changes, hyperintensities because metabolic disorders affect the global pallidus more, the basal ganglia. You can see that both on MRI, you can see on MRS changes. And in addition, when you have a disorder, like in this case, which is glutaric acidemia, and you're building up acid, that is damaging to the brain and some of those vessels behind the eye, which makes them leaky, and it might cause some small bleeding like you see in the posterior pole where it's very vessel rich in number 1. But that looks very different than the diffuse bleeding and retinal hemorrhages you see with acceleration and deceleration injuries like in number 2, correct? So this is where we repeat that subdurals and syndromes are syndromic. And so that is how we diagnose glutaric acidemia type 1, that 1 in 30,000 or 40,000, because they present differently with these viral illnesses. In this case, like in many, there was a family history. The family was consanguineous. They didn't have a newborn screen. 98% of babies can be detected by newborn screen, but if you're still worried about it, a test called quantitative C5DC in the urine reveals this acid built up in the blood. You see macrocephaly, that dystonia, the subdural global pallidus. Molecular testing, which has to show 2 variants, is virtually 100% diagnostic, and then the treatment can be initiated. And what's amazing about this treatment is if you do diagnose these patients early and you treat them with fluids and a low protein diet during illness, they do not tend to have stroke or catastrophic injuries. And by age 4 or 6, they may never have a stroke and be perfectly okay. So that's why we diagnose these kids. And when you look at the literature, small studies again show that for GA1 cases, the majority follow suit and have other signs on their MRI almost invariably. So the key point number 7 is that pan-metabolic labs are not indicated here. You don't know how many times I come to a baby with these cases as a genetics consult, and before I've gotten there, neurology or another team has ordered plasma amino acids. Well, PKU, which is a condition, one of the first on the newborn screen, it was diagnosed in people who had intellectual disability in institutions that were older, but they didn't present with brain bleeds. Same for MSUD or maple syrup urine disease or urea cycle disorders, which present with high ammonia and cerebral edema in the first days of life, and you need to put them on special diet. This is a very different presentation. And why are we ordering ceruloplasmin and copper levels on children that have typical size and none of the facial features? So pan-metabolic labs are not indicated here because we want to spend our time on the labs that will count and help these children, right? And so now we'll take a final case. We'll go very quickly, and in the last 5 minutes, what we're gonna do is we are going to summarize and make sure that everybody is on the same page with this process. Summarize kind of everything we've learned. So a 4-month-old with vascular EDS presents with increased lethargy and seizures, a shortfall from the bed. Parents are very prominent in the community, and the workup reveals multiple retinal hemorrhages, no fractures, and the medical team makes a diagnosis of child abuse. But the defense expert, after the multidisciplinary evaluation is done from an outside hospital, finds a variant in a condition called Ehlers-Danlos syndrome vascular type and writes, in my opinion, this confirms the diagnosis of EDS type 4, formerly known as vascular EDS. It causes easy bruising. That's why the child had bruises. It causes the injury. Quality of life is very important for this child. And so we have learned that we are going to review the case step by step. We're going to do fill in the box genetics like I showed all of you. We're going to compare and contrast with the disorder, and we're not going to forget the baby and whether the testing is useful for them, right? So for the clinical case, it was abusive trauma, no family history like we see in my patients with vascular EDS with aortic rupture, carotid dissections, typical growth patterns. There was an absence of club foot, hip dislocation, translucent skin. And as I'll show you in a second, the subdurals were in a different location, and when we searched the variant, it was reported once. And so when you look, sorry, before I do that. Okay, yes. And so this child, you can see from the literature, is 14 and sadly had a lot of the features and died of aortic dissection. Males who are 14 very rarely are the ones who die earlier of things like aortic dissection, not brain bleeds. And he had a strong family history. But now, if you've never met somebody with this disorder, that's about 1 in 200, if I can figure out, then today the patients will come to meet you. So you can go to my daughter's favorite TikTok. Sorry, I don't have it. You can go to Instagram. You can see.
Hey guys, it's Katie and this is My Life with Veds. Today I'm going to talk to you about my characteristics of vascular Ehlers-Danlos syndrome and my diagnosis story. Some people like to think about these as symptoms, but I think about them as characteristics because they're really genetic features in my body that really have been with me my whole life. So I really just don't think about them as symptoms, although there are a couple that I do. There are some characteristic features of vascular Ehlers-Danlos syndrome that I have that not everybody has. There's a lot of people out there that don't. So it's just some people have a lot of them and then some people don't really have any outward signs. I just happen to have a lot of the outward signs. So I'm going to start with my little nose. This is something that my mom doted over when I was a kid. She just loved my little nose. It's so narrow and it's very thin. I didn't personally like my nose because it has this bump in it right here. You can see like on the profile of my nose, there's this little bump. And it's something that I just have never liked, but if you just look straight at my face, I do kind of like my nose. The thin, narrow nose is a characteristic of vascular Ehlers-Danlos syndrome that we just didn't know about. I didn't find out about my VEDS diagnosis until I was 28. We'll talk about that later in this video. Another thing is that
for the sake of time, she also shows her hands, which I don't know if you notice, have a very classic aged appearance. So there are so many, and small joint hypermobility of the toes and the fingers. And so the patients will tell you themselves the signs, the symptoms, how they were diagnosed. And if you get to know their stories, then you really can compare and contrast and know the different types of history. Let's see if I can, okay. And also it's so important, back to the radiology, to really think about the location of these things because subdurals are under the dura. But the patients that do present in their 20s with these vascular internal carotid dissections, you can see that in the vessels. That's why it's called vascular, correct? So there is a real difference. And when you review the literature, and a lot of it was done by our very Melanie Pepin and Dr. Peter Byers, thank you. They have reported hundreds, thousands of cases, and they did not find any early life death due to arterial rupture in small children. Thank you for your work. I see Dr. Byers in this room. And same with the cerebral vascular complications. They were not there in early childhood and they looked very different. And so the literature matches what we suspected in this case, which that it was child abuse. That variant, and Dr. Peter Byers helped with another very similar case, was found in the general population, autosomal dominant, and the testing was indeed child abuse. So I've given you a lot of key talking points. But basically, they all are saying the same thing, that you went to medical school, that you were trained to put on, I know we don't use a white coat in pediatrics, that white coat, because really you're doing this amazing pre-test, post-test probability Bayesian analysis that's better than any genetic test you could order. And rare does not mean mysterious or difficult to diagnose. These kids have signs and symptoms. So when you spend a lot of time with them at the bedside, that is really the most evidence-based, best way to make a diagnosis. I'm so grateful to all of you for that work at the bedside that you truly do step by step, every case, every time, for the sake of our children, to really provide clarity to each one of them. I'm grateful to all of you and Dr. Hines, one of my child pediatrician colleagues who reviewed every one of these slides, and Dr. Jackson, and we've been involved in some of these cases. And all of you here are really the best child advocates. You're world renowned in the country. So it's been such a pleasure to talk to you today. Thank you.
Thank you so much. We have a few minutes left. If you can hear my voice and you're online, you can type into the chat box. If you're in the room, raise your hand. I'll bring in this microphone. Everyone's taking a picture of the thing. No questions. I was going to ask you a question about the birth testing. I'm losing my...
Oh, newborn screening.
Newborn screening, thank
Yes.
you. I know it seems to be different state by state.
Yes.
Is there anything that you see coming down the pipeline that you would be advocating for in the world, and why is it so different state by state?
Yes.
If you know.
So yes, I do. So the American College of Medical Genetics has come up with kind of the mandatory ones that they recommend anyway, that they want to be implemented. And they have, I believe now there are 30 something conditions on that mandatory one. Not all states follow the mandatory guidelines, but those have a threshold of diagnosable early by the newborn screen, treatable in the early period, and that would make a difference to the child. And so I think that is the most helpful committee vetted panel. There are a lot of political or other reasons why the states are differing in their particular panels, but we really do want to diagnose those metabolic conditions like PKU, where if you offer a treatment, then you're going to have lifelong benefits. Down the pike in this country, there are more and more people who are advocating for universal exome, broad genetic testing. That's a whole different topic. Thank you.
And then there is a question online from Anita Beck. Thank you for this terrific talk. Much appreciated. As geneticists, we struggle with nutritionists describing severe malnutrition in children with weight less than first percentile. This is even if the length and height centiles match with a weight length or BMI in the normal range, even if they have always been small, even if the child has a known genetic condition that leads to short stature. They have used this as a point for child abuse cases. How can we educate further?
Yes, that is actually one of my projects, which is rare disease growth curves, and talking about, and I know there's controversy about this, but 10% of children with have genetic disorders, and 40% out of those 10% grow differently than typical children from the very, very beginning. And so what you're really wanting to focus on is their overall growth pattern. And she brought up a very good point that when the weight for length is reassuring, that goes against the diagnosis of malnutrition, because our kids, when fed, and often many of them have G tubes, they will grow and they will have appropriate weight to lengths. I worry more for growth faltering when you're seeing people meet criteria for malnutrition and the weight to length or BMI is very low, 2 to 3 standard deviations. And especially when you hit 3 standard deviations below the mean, that's critical in all of our children, including those with genetic disorders.
Thank you so much.
Thank
We're
you.
almost out of time. We really, really appreciate your enthusiasm and all of your time you spent teaching us today. And thank you so much for being here.
Thank you.
And thanks, Dr. Webster, for having her. Thanks, everybody.
Thank you.
See you next week.